So folks that are coming on board here, welcome to our September running of our Valuation Lab chat. This is sponsored by the University of Minnesota Medical Industry Leadership Institute and our Evaluation Laboratory. It's a way to have an exchange with different topics in the great health space. And today we're really privileged to do this with my co-host, Tom Gunderson, who's our chair of our executive in residence group at the Carlson Medical Industry Leadership Institute, to talk about price transparency, and particularly the new insurer federal rule focused on insurers to disclose prices that, as people have been noting, at least in the press, that the size of the files is equaling the video libraries of Amazon, Netflix, and Hulu combined. So there might be some myth to that. So just so those that are new to this whole process, this is a 30-minute conversation that's recorded on the record. So whenever we'll say what we say carefully, you as well. Then we have 30 minutes off the record that's more for Q&A, and do what you want to do in that time. But we want to make this conversational. There's no PowerPoints. And from here, I'm going to turn it over to Tom, and then maybe to Theo to give a little bit of background. But first, Tom, maybe you want to introduce them, or do you want me to? It's up to you.
I can do the next handoff. Thanks. So just one other on the housekeeping. It looks like most people online already have this in their pocket, but if we all go to mute, if you do have a question during the first 30 minutes that we're recording, go ahead and put that question in chat and we'll review that. Otherwise, questions can be saved for the non-recorded part that'll start at 5:30. But with that, we've got a full group both in the audience and on our panel today. And maybe as we talk about transparency for the price transparency for the insurers, maybe Theo, you could give us a little bit of background on how we got here from 2019.
Sure. Hi, everybody. Theo Merkel. My role was that I was in the White House starting in April 2019, and had the privilege of sort of overseeing this project for the executive branch. And I mean, by the time that we were in 2019, basically the Trump administration's attempts at healthcare reform through legislative measures had already failed, and we were looking for things that we could do to make healthcare markets work better from a regulatory standpoint, things that we had the authority to do. And I mean, Larry Van Horn and there was a lot of research out there on price variation within healthcare. It was quite obvious that I think everybody here has tried to figure out the price of things within healthcare. It's almost impossible. People will say this is evidence of how healthcare markets don't work, but we actually think that there's a lot of evidence. And if you look at it historically, this is part of the way that the federal government has prevented healthcare markets from working. So we took a long, hard look at what statutory authority we might have. And, you know, President Trump really was really drawn to this effort, I think, because of the logic to it. And there's a bit of moral clarity to it, right? That people should be able to know what the price of something is prior to purchasing it. So, you know, this is one of the areas where the Trump administration, everybody on board was rowing in the same direction. We put out a proposal that is composed of pretty much three elements. There's a hospital transparency rule that went forward about a year ago. What we're talking about here today is the insurer transparency rule that has two elements to it. One is it requires a large disclosure of these files, which Steve has talked about is quite large, but this is really the meat to the transparency rules, and it's requiring insurance companies to put out provider-specific prices for every procedure that they have negotiated in network. And then out of network, it's requiring a time frame of historical charges to also be disclosed. And then the third element, which will be out next year, is that it will require a direct-to-consumer price tool that you will have available to you, so that you will be able to look up your prices in advance. The first two parts have been implemented, but there's still a lot more work to be done, because getting the data out there is only one element. And I think Larry can probably talk about a little better than I can, sort of what that looks like and some of the challenges, but also potential of the information that's been put out.
Yeah, I mean, you want to pick it up there, Theo?
I think so.
So everybody who's on here today needs to understand that the only price that matters is the net contracted rate between the payer and the provider. So charges are meaningless. All of these other things that people assert that we should pay attention to don't matter. All that matters is the net contracted rates. And as part of price transparency, the provider price transparency in January 1st of 2021, hospitals had to disclose the provider contracted rates that they had with each payer. And they were not too inclined to do so. They drugged their heels, and they were under the assumption that because the Trump administration had exited and the Biden administration had come in, all that stuff, we don't need to worry about it. And then, blessed be the case, the Biden administration said, whoa, wait a minute. No, you got to produce that, and we're going to increase the penalties, and House Energy and Commerce weighed in. And so as of just recently, they've started putting forward pretty reasonable monetary civil penalties on hospitals for not producing their prices. The prices that they had to produce are the same, should be the same information that the carriers produced on July 1st. And what the insurers did is they dumped everything. While the hospitals were fighting and screaming to do anything, the carriers just said, here it all is. But they didn't do it in a way that's usable to just about anybody who isn't kind of imbalanced and spends their time in the world of JSONs and compressed files and whatnot. And so what the carriers did on July 1st is they dumped a tremendous amount of this contracted price information out into the public domain. It's out there. Anybody can go and get it, but you have to be a real geek and a pointy-headed person to actually use it. And they did it in such a way that it was very user unfriendly. So, as a little bit of detail here, if you take an insurance carrier in a state, they might have 1 or 2 or 3 networks with different contracted rates, but all the employers in the ASO space are riding on a number of different networks. And there should be a common price they could put out across all the providers depending on the network. Well, they didn't do that. They basically said for every single employer, here's the contracted rate file for that employer. And then to add insult to injury, they basically replicated the entire CPT code distribution of erroneous and irrelevant prices for every single provider. So what happens is a primary care doc, an internal medicine doc, never does heart transplants, never does transurethral prostatectomies, never does a whole bunch of things. They only do probably about 100 to 200 CPT codes. But now that individual provider has 10,000 lines associated with all the stuff they don't even do as part of what the contract might be. And so it blew up these files into a form and a magnitude that is really unfriendly for the uninitiated. Thankfully, there are a number of individuals who uncompressed them and are working on structuring that data now, but it needs a lot of massaging to make it useful to achieve our end game of making the true price, the contracted rate between a provider and a carrier, public at a level of detail that's actionable.
So thanks, Larry, for doing that. I think as we're getting into the conversation here, I want to introduce Cynthia Fisher. So Cynthia, you were the primary mover and advocate for a lot of this from the get-go. If anything, actually, I met you through Larry, and actually in part through Theo. I think there was a weird situation where when I was working in the White House, Larry told me he was coming to town and we should get some dinner, and he's going to be meeting folks in the White House. And I think basically I was, when this was first proposed to me, Larry, if you recall, I was sort of like in disbelief, like, really, we're asking for all these prices, and what possible statutory component do we have? So Cynthia, you actually did the homework to more or less say that that's actually possible, because I think even when I had the White House meeting after Larry met with the president, I pretty much was looking at your document under the table inside the executive office building, more or less verifying that this was even possible. So tell me a little bit about more where, I mean, we are actionable now. What is your advocacy group doing? And then I guess what risk are you concerned about right now, if anything? Are you overjoyed with how it's gone so far? And you're on mute.
Thank you, Steve. And yes, we did a lot of homework, hiring a couple of law firms, well aware of regulatory laws, and found 3 800-pound gorillas of existing law that had never been made into rule of law that empowered consumers to have the right to know prices in advance of care. And as the Trump administration so well did, the strongest one was the Affordable Care Act, which they found, the great language in it that gave us that right. So you look at 3 presidents, Obama, Trump, making it happen, and then Biden keeping it, which is a big deal. So for that, we're elated, because you also have ERISA law, and you have also conditions of participation and payment in Medicare. But where are we now? Our organization still keeps going on the legal front. And I would add a couple of things that also the Trump administration did that it happened with Congress because of the efforts. And that's the No Surprises Act, which is sorting itself out. Obviously, we have to go through lawsuits to get to the final act, so to speak, but implementation. But also, I think the other big deal that happened was a Consolidated Appropriations Act. This is huge too. And that is that part of the transparency efforts that came from the Trump administration was also to get the fee schedule of all the middle players, and starting with the insurance brokers. And we're starting to see the great reveal for employers to understand just what they're paying in fees for all the many layers of services of insured care. And then finally, the health claims data. So as Larry well knows, these should all match. The negotiated rates that Larry mentioned, the health claims data, and the hospital prices should all be the same price. Right now, early on, what we're seeing is, by and large, our organization has a research team that looks at the hospital prices. Every 6 months, we're doing a watchdog report. And sadly, I can tell you that the hospitals have put together breaks on compliance. Our first report 6 months in was 5.6% of the hospitals were complying. Our second report showed 14.6% complying. And now our third, now nearly 20 months into the rule being in place as law, we're at only 16% compliance, and we looked at 2,000 hospitals. We just started looking at the transparency and coverage data, and Larry is spot on. I mean, what is really egregious is the breadth of data, but it's still thin. And it's and as Larry said, there's some things, because they're doing a huge dump based upon provider on every code, that are just erroneous. So it does have a lot of errors in it. However, what we're seeing preliminarily, which is a little great reveal, is that where the hospitals are flouting the law based upon a commercial plan negotiated rate, they're largely putting NAs in the field, or just asterisks, or not showing pricing data, saying they can't come at it. That's just wrong, because we're starting to see that data in the transparency and coverage files. It's really hard to access because of the gaming of trying to kill by delay by the amount of data that's been dumped in the format that it is. However, there is a great reveal in these early bumpy stages. So that's where we are right now. And I will say, from our last report, finally, after a lot of pressure from ABC News and NBC News, that yours truly organizations might have had a little bit to do with Secretary Becerra, we finally saw 2 hospitals get enforced out of the over 5,400 that are not complying. And amazingly enough, within 2 weeks, our research team found that once they were fined $1 million, so that says enforcement fines does work, their files are exemplary and very easy for even a consumer like myself to go online and find the pricing. So I just want to say that enforcement is really important. However, this administration has been slow to act on enforcement. And I think that's also another factor that's going to be important from the Department of Labor for the ERISA plans, but also the state insurance commissioners or the state agencies that have jurisdiction over compliance of the transparency and coverage rules for employers.
So let me summarize, if I can, what I'm hearing from you guys, and then ask a question on sort of what's next. But a major breakthrough with the hospital data, and now in July of this year, the insurance data. On the other end, the next steps will be getting a consumer level tool to be able to understand all this. But Larry, based on what you said, I mean, let's assume that the insurers and the hospitals get around to doing this. Let's assume that the data have quality. It still sounds like we might be a ways away from actually being able to do something with these data from a consumer or even from an employer standpoint, until somebody comes up with the Rosetta Stone and enough pointy heads to make it simple.
Well, I mean, Tom, there are people working on the Rosetta Stone, and it's not going to be that big a problem to put it together once we get the data normalized. That's not a big lift. The point I would make, and I have a paper that's coming out this month on this, is that unfortunately, Americans don't have a good understanding of the role of insurance and the amount of price variation. So I did this big national survey of Americans' attitudes towards price transparency, blah, blah, blah. Two interesting points. One is the majority of Americans thought that because they have commercial insurance, they don't need to shop for price. The insurers already solved the problem, which is wrong. It's fallacious. Okay. Two is they didn't understand the magnitude of the price variation that exists out there in the market. They thought, they're all charging roughly the same. All the providers are roughly charging the same. If people have these incorrect beliefs, their incentive and their engagement in actually using information is attenuated. So the reality is, going and buying medical care is like going and filling your car up with gas, not knowing whether you're going to spend $2.50 a gallon or $12 a gallon until after you already filled your tank. That's U.S. healthcare. And one of the first things that I believe needs to happen is we need to take this data and start hammering on it on a market by market basis, showing people how much price variation there is, because that is the risk of not knowing. And right now, Americans have no idea on the magnitude of the price variation. They think their insurers solved the problem, and all of that's false. So to me, step number one, inform Americans that this is a rampant free-for-all with massive price variation. And then two, give them the tools to shop. But you got to do the first as well.
And I do just want to mention something. When we were developing the rules, we were acutely aware that we wouldn't necessarily be able to anticipate all the challenges that would happen down the road. And frankly, we had, I think, the humility to know that like we were not going to be able to craft a rule that could anticipate those challenges. So what we wanted to make sure that we did was that we got the data out there, and that was the priority. Acknowledge it, like, as opposed to HHS or CMS exactly specifying the way that everybody needed to present it, the file type, everything. We wanted the data out there. We know that this is going to be iterative, and we know that there are going to be a lot more intelligent people on the outside. There's obviously smart people that were helping us with the rule on the inside, like Steve, that had a knowledge of insurance companies and how their data is formatted. But we did not go in thinking that we knew all the answers, or we knew exactly how the information should be presented. So our priority was getting it out there and allowing people to manipulate it, to play with it, to clean it up, and turn it into something useful.
Yeah, I want to jump on the back of what some points that Theo made there, is that this gets down to a very philosophical issue. People ask me all the time, what is your plan for how this is going to all play out? And I say, whoa, wait a minute. This isn't the Soviet Union. There isn't a central planner here. I believe in markets, and you put the information in the markets and it will solve the problem. This is America. And so I have 100% faith in, if we perfect the markets and we overcome some of the impediments to the healthcare market functioning well, the market will configure solutions that meet the needs of consumers. I don't need to prescribe it. It'll solve it.
So I want to make two quick comments that sort of layer on this that are useful, I think, to know. One of the arguments that came up a lot while we were doing this was, if the prices are revealed, providers will collude and prices will go up, and it'll be uncompetitive because everybody gets to see what else is going on. One of the things that we did when specifying it was to say that the files, unlike hospitals, the files had to come out monthly. And I'll give credit to the insurers. They are dumping these files out exactly on like September 1, July 1, October 1. And I'll ask Larry to make a comment. I mean, you've been tracking some of it. You actually see some movement from month to month, which is great. And so my point, because I won't say who, but I remember toward the very end of the administration, people were getting anxious about this thing coming out, about the prices. And I think Theo connected to somebody elsewhere in the administration who was very worried about this. And I said, the reason why we specified monthly was that if we see evidence of price collusion and price fixing, more likely, that would give something Department of Justice, antitrust, and FTC to do for antitrust enforcement that normally they wouldn't have the data to do. And so that was partly the rationale for that. And
while this was going on, Steve, I met with the FTC, and they had some unfortunate memos from Minnesota way back when that were not relevant, but they got construed as being relevant. Remember those conversations, Cynthia?
Yeah, that was a fun meeting, Larry.
Yeah, but the point is that this is a space in which there is a lot of information. The 835 electronic remittance set is out there. And my perspective, even barring this, is you don't have an industry where you have more real-time visibility into the contracted rates than you do in healthcare. So if there was something going on, we'd know it and you'd know it. So don't worry about it.
One last comment, and I guess I'll give credit. I can't believe I'm saying clever points to the insurers for this. At the end of the day, as big as these files are, we only asked for 10 data fields that are relatively small. They managed to take those 10 data fields and spin it into the most large gargantuan thing they ever did, mostly by just basically, to Larry's point, just making the biggest out of network file ever for every possible contingency and just letting it gunk everything up. And it's a challenge for any casual user. I mean, I remember when I did say when we were specifying this stuff, Theo, like make sure they're text delimited or Excel files or whatever you want to do. And in there, JSON was included because it is a text file, but it is designed for Java programmers. And it's a challenge too, because of the way it's actually structured. Just in terms of just to Larry's point, it gets geeky. You really need to have a pretty impressive computer to basically strip those things to a level to get to the where you want to be. It's not, if you talk to reporters out there, whether it be Anna Matthews, Wall Street Journal, they're frustrated because there's like a whole different level of competence to basically just look at one file for one carrier in the state.
Yeah, Steve, that's absolutely true, even with the hospital files that we're seeing the gaming too, but especially with the transparency in coverage files. You know, I think one of the things as we go forward that is needed is a level of standardization. And if one could think of the ideal world, you know, cloud computing can take us to a very big space, but if we can streamline the transparency and coverage data as well as the hospital data and have it as a part of compliance be uploaded into a cloud where it's easy, the links are easily accessible to any tech developer to be able to parse in a standard format, that would catapult us forward to be able to create a market, to create markets and have this information get out into the ether. The other thing that's really needed is attestation of and certification by the CEOs and CFOs of the major carriers and attestation of those third-party administrators and carriers that are providing these negotiated rates for the employers and the hospitals, because the quality of that data is being gamed. We are seeing, we're seeing some of the data be filled in just with the high-level charge master rates and not into the negotiated rates. We're seeing a lot of missing data that would be appropriate to say they have to have these numbers in order to do their M&A deals, in order to do any of their billing, they have the rates. And so it can be done. And that is why I think there are almost calls for an SEC type of certification, just like we have. I'm on the board of public companies. You know, your CEO, CFO have to sign the financial statements are indeed true to the best of their knowledge. And so I think we need accountability at the personal level to get us to making sure this data is also quality data. Yeah,
I mean, you know, we've basically got three pieces of information here in prices. You've got the provider price transparency, where they haven't really done a good job. And that's what Cynthia is referring to. The other visibility into prices is obviously the insurer price transparency. And that data, that's pretty reasonable. The third is the 835 data, which is contractual dollar flows. It's real. You just have to know how to work with group and reason codes to make sense out of it. But it's you know what the prices are. I think, you know, as we're coming up to the bottom of the hour, a point that I'd make is, and I'm following the chat here. Mark Samuel made a very good point, and that is, I view this price transparency as the first domino to tip, and I'm more interested in the fourth or fifth domino, and actually being able to present to Americans what a 99213 contracted rate is for United, Aetna, Cigna, and various carriers. Is not that useful to an American, because what they really want to buy is a doctor visit. And so what we need to have happen is we need to change the definition of the unit of service away from the AMA hegemony on the definition of medical care, which was where they make all their money, to something that is more consumer friendly, like a doctor visit, or I need to have a colonoscopy. We know that takes a professional fee from a GI, anesthesia, PAP, facility, bundle it together, give me a single contracted fee, right? So I think it's less about where we are now. I get more excited about domino 2, 3, and 4. And once the information is out there, there'll be a lot more pressure to push that forward.
So we're about to go off the record, which will be kind of fascinating given the chat. Lots of stuff we can talk about. I just want to concur one thing Larry said, at least efforts I think all of us might agree with, Cynthia, Theo, and Larry. We've talked about this before. It's like we all knew this would not be the end of it, but the thought is like this is the necessary but not sufficient condition to move forward. It had to happen, but it to your point, Larry, it can be parsed to get to the next level. But you know what that new innovation will be is a entrepreneur's playground, basically, which is probably why we have a bunch of them here that are normally not our students, which is great. So with that, we are going off the record. So I want to officially thank Larry, Theo, and Cynthia for chiming in, and Tom. So Jessica, take us off the record, please.